So anyone you want to know in the world, or get connected to, Utah is your man to make that connection. So please put your hands together for Utah.
Very exciting music. I'm so happy to be here. Very happy to be here. Thanks to Martin and Beatrice for organizing this meeting, and obviously also thanks to Nadine and Damien for hosting this event. Mauritius is truly a special place. My name is Yuta Lee. I'm the founder and CEO of Excelera Biosciences, and we are working with the human trophoblast stem cell. Imagine starting a therapy at age 30. And when you're 100, you still have internal organs of a 30-year-old. That's our longevity vision, and that's what we're trying to achieve. Now, our pathway and approach is with cell and gene therapy, more specifically stem cells. And our stem cell platform, the human trophoblast stem cell, is actually discovered by my father, who's an MD PhD. He got his MD in Tohoku University in Sendai, Japan, and his PhD at St. Bart's University of London. In 2003, he was performing a salpingectomy for an ectopic pregnancy, and he discovered the human trophoblast stem cell from the preplacental tissue of that ectopic mass, and I'll describe that in a little bit. So we're taking two simple steps, actually not simple at all, but two very long steps. We're going to try and solve some sick care, and they're going to move into prevention using these cells and the exosomes coming from it. But today, I kind of want to go back to basics. I want to spend some time telling everybody about cell and gene therapy and what we've progressed to today, and then we'll spend a little time talking about our approach. So what is a stem cell? Now, for a lot of stem cell scientists here, I'm going to apologize first because I'm going to violently simplify a lot of this so that everybody can get on the same page, okay? A stem cell is a cell that can self-renewal, it can create another copy of itself, and it can also differentiate into all the specialty cells in our body. And this is how we regenerate and how we recover from damage. Another concept in cell and gene therapy is autologous versus allogeneic. Autologous is when you take something from your own body, modify it, and put it back, okay? Allogeneic is when you take a healthy cell, modify it, and then put it into your body as a therapy. Now, there are some disadvantages and advantages. For the autologous cells, the disadvantage is that they're really hard to scale, right? Every patient that comes in, you've got to do it all over again. But you don't have any rejection issues because they're from your body. With allogeneic, the big disadvantage is obviously the rejection issue, right? Because you're taking a foreign cell and you put it in your body, it'll get rejected. But you can take these cells and scale them and really reduce the cost, okay? Hospitals are more in tune to using autologous because it's a service model. Every patient that comes in, they have to treat them before they leave. Biotechs and pharmas love allogeneics because they can mass produce it and they can distribute it. That's what they're really good at doing. Okay, cell therapies is using healthy cells to replace or repair damaged cells. Now you can take a stem cell, which is the most original cell, differentiate them into immune cells to go kill something like cancer, or you can take a stem cell, differentiate into the various subtypes of cells to go cure an organ. Neurons, for example, pancreas, liver, or any other organ in your body. This is where all the stem cells come from the context of fetal development. So the first 8 weeks is embryonic. We're just still cells. Between 8 weeks to 38 weeks, when a baby comes out, it's called a fetal period. So the body's forming, the organs are forming, and on average, at the 38th week, the baby's born. Beyond that, everything's adult. Okay? So the earliest cells you could possibly get are human embryonic stem cells. These are embryos left over from IVF clinics that you can use for research and also develop therapies, but that has a very heavy ethical concern attached to it. Next is our cells, the human trophoblast stem cells, and we get them from an ectopic pregnancy between 4 to 8 weeks post-fertilization, but still in the embryonic stage. Everything in the fetal period, usually from an abortion, so not many people want to touch that. So you get most cells from the birth event, mostly MSCs, cord blood, placenta, amnion, etc. And from the adult, you can get cells from fat, adipose, or bone marrow. And of course, Michael Ringel already talked about Shinya Yamanaka and the iPSCs, induced pluripotent stem cells, where they use a virus to change a cell all the way back to the stem cell state. Okay? And on this spectrum, all you have to really realize is that the earlier you go, the more biologically active the cells tend to be. Another part of the cells that you can use are these extracellular vesicles, or some of you may have heard of exosomes. Right? Exosomes, or extracellular vesicles, are these bilipid layer bubbles that are spewed out from cells, and that's how cells communicate with each other. And inside these bubbles are usually DNA, mRNA, RNA, other proteins. And neighboring cells, when they see this, they will endocytosis, swallow them, read the message on the inside, and have an action potential. Okay, so a lot of people are using this to send messages to cells, either to rejuvenate them, to have a specific function, to give them proteins that they lack, etc. So it is all in the pipeline now. Gene therapy is inserting or replacing defective genes with functional ones, right? So there will be a cell with a non-functional gene. You usually use a vector, like an AAV or a lentivirus, to load the DNA that you need, put it into the non-functioning cell, and then fix it. Now, there's a new category called gene-engineered cell therapy. And you may have heard of CAR T therapies. CAR T therapies was first reported in 2013. And what they did was they realized that your immune cells could no longer recognize the tumors in the blood of your body, leukemias, right? And so what they did was they engineered in a marker to specifically hunt down these blood tumors, right, leukemia. And the marker that they found in the beginning was CD19. So basically what they did was they took your blood, they validated that the tumor, the leukemia, had a surface marker called CD19, and then they would load up an anti-CD19 onto your T cells, grow them all out, send them back in your body, and basically telling it, if you see a CD19, hold on to it and kill it. And it's very, very effective. Now, there's another new therapy called TCR, T-cell receptor, that was recently approved by the FDA. And what they're doing is using a T-cell, engineering in a marker called MAGE-A4 to recognize an MHC. Now, MHC is your cells, when they are attacked or something goes wrong, raises a little flag and presents the antigen to say, hey, something's wrong here, come get me. And the T cells will pick that up and kill it. Now, CAR T therapies have been very effective, but mostly for blood cancers, leukemia. Okay? But unfortunately, blood cancers only account for about 10% of all cancers. Right? So the biggest part of the pie is still with solid tumors. And this is where TCRs are becoming very effective. Right? So the first product was passed by the FDA for synovial carcinoma. Very, very effective and very exciting. And of course, I don't have to repeat this, but Shinya Yamanaka reported this iPSCs in 2006 on the induced pluripotent stem cells. And they took a virus, a Sendai virus, loaded up 4 transcription factors, and was able to turn a skin cell all the way back to a stem cell state. Right? So But the significance to longevity is actually pretty incredible. Because if you can reprogram one cell to go back to a stem cell state, that means technically you can reprogram every cell in your body to an earlier state. So that means longevity and aging is really just an engineering problem. And this is where, companies like Michael Ringel's Life Biosciences is very exciting. All right, so this is where we are at with cell and gene therapies. There are currently 43 cell and gene therapies approved by the FDA. 18 in cell therapy, 13 in gene therapy, and 12 in the gene-engineered cell therapies, or CAR-T or TCRs. And just to take a look at the pricing and compare, right? What you see here are 4 major bio areas, the US being the biggest one because the CAR-Ts were developed there, and this is all the CAR-T pricing. As you could see, the average cost in the US is about $458,000, and in Europe, the same 6 products average $356,000. In Japan, $229,000, and in China, where they have their own CAR-T therapies being developed locally, average $163,000. So what does that mean? That means America is still the best place to market something, right? So if you're developing a therapy, go to the US. These are some of the most expensive products in the world in these categories. In stem cells, $2.8 million for one shot, and this is for beta thalassemia. In gene therapy, $4.25 million. Pretty incredible. But this is for a rare disease called MLD, and it affects infants when they're born. And these infants usually die within 6 months. Hemophilia A, $21 million. Sickle cell, 4 to 6. Thalassemia, 5.4. But the blue is the one-time cost for the gene or the cell therapy. So when you look at it in this context, all of a sudden it makes a lot more sense. Especially for hemophilia A, you can spend $2.9 million and save the rest. That's the idea, right? So the only thing I want to say here is that, when you see these gigantic price tags, you have to really look at it in context of the lifetime cost of the patient. And it puts a very different perspective. And especially if there are any government finance people here, think about this. Also, I want to say that, around the world, we're tracking a lot of cell and gene therapy companies. There are a lot in America, North America. Asia is coming up. And Europe is slowing down a bit, and the rest of the world. And I'm actually quite optimistic that you guys are going to do something very, very cool to catch up to the rest of the world relative to these therapies and these companies. And it's a function of the regulatory environment and government support. So here's our approach to longevity. So as I said before, our cells, the human trophoblast stem cells, are sourced from an ectopic pregnancy. And this is what this is. On the left side, you see a blastocyst at 5 days, and at 5 days, it differentiates into 2 types of cells. The trophectoderm, which later becomes the placenta, and the inner cell mass, which later becomes the baby. Okay? And in ectopic pregnancy, what happens is the embryo travels down a fallopian tube and gets stuck. And it'll sit there and grow until it bursts. And if it bursts the tube, the mother may die of internal bleeding. It's actually the highest cause of death in first trimester pregnancies. And so what typically happens is a woman will feel sharp pain, go into the ER, get scanned. The doctor will say, ooh, you actually have an ectopic pregnancy. They have to schedule an emergency salpingectomy where they ablate both sides of the mass and they use a scope to remove the mass. And once they do, all they have to do is give it to the pathologist to double check, and they can throw it away. And the reason why they did that, why they can't throw it away, is because the blastocyst on the left side typically needs to implant into the mother by day 7 or day 8. But you don't discover an ectopic until 4 to 8 weeks. That means there are many weeks in between where the embryo is not connected to the mother, no nutrients coming to it, so all OBGYNs understand the embryo to be non-viable. Now, my father, being an MD PhD, performed this procedure back in 2003, took the mass out, and I was thinking to himself, why are we throwing this away? There's got to be amazing stem cells in here. But to avoid all the ethical issues, he scrapes off the chorionic villi, the preplacental tissue, hands the rest of the mass back to the pathologist, who checks it and throws it away. And now we have the earliest stem cells that you could possibly source without any ethical issues. These cells have pretty interesting characteristics. We're able to drive them out to 85 population doublings. Now, population doubling is one cell turns to 2, 2 to 4, 4 to 8, 16, et cetera, 85 times. And that's enough to grow e to the 25 cells. If you can imagine a number 1 with 25 zeros behind it, that's enough cells to grow 2 trillion human beings. There literally are not that many people on Earth. Okay? So scale solved. MSCs are sitting down by 25 population doublings. And it's a problem because every time you source a new cell, the FDA or the EMA will consider it to be a brand new product. You've got to take it through the FDA process all over again. So it's very, very hard to maintain and to get enough scale to lower the price. With 85, you have a lot of scale, and you can really reduce the price per therapy. Our cells also express HLA-G. Now imagine this, the embryo is half the father's gene and the mother's gene. So how come this alien thing can attach itself to the mother without her immune system going completely haywire, trying to reject it? Well, it turns out the HLA-G has that function. It dampens down the mother's immune system so that the embryo can stay attached. And this function is so powerful that now you can take an embryo and have a surrogate mother carry it to term, a woman that's biologically not even related. And our cells express the HLA-G, and when you differentiate them toward neuroprogenitor cells as well as pancreatic progenitor cells, the HLA-G sticks. That means our cells are really ideal for allogeneic therapeutics. And we've taken these cells and put them in 5 different animal studies, all with human cells in immune-competent rats, and they survive, they home, no teratoma or tumor formation, and we get all behavioral improvements. So we're the only cell platform that has scale and immune privilege in the same package. Now, quick story. About 2.5 years ago, a researcher at the National Institute on Aging calls me up and says, Yuta, I saw one of your presentations in Seattle, and we hear you have one of the earliest stem cells you could possibly find without ethical issues. I said, yes, we do. In fact, we are already taking it into GMP. He says, can you send me all of your conditioned media? And at that point, we had saved up 6 liters of frozen media, and we sent it to him. Then I called him up, and I said, what are you doing with this stuff? And he proceeds to tell me this story about the heterochronic parabiosis. So if you're in this industry long enough, you'll hear about this story. Back in Stanford, about 20 years ago, these researchers took 2 mice and stitched them together so it would have one circulatory blood system. One old mouse and one young mouse. And they discovered that the old mouse is biologically getting younger and the young mouse is biologically getting older. Whoa. Second experiment, they did not stitch them together, did a plasma exchange. And the same thing was happening. So what does that mean? That means rejuvenation of the old mouse is purely a function of the proteins coming off the blood of the young mouse. So if you can rejuvenate an old mouse just by using the proteins from the young mouse, what happens if you take the proteins coming off the youngest stem cells you could possibly find, but without any ethical issues, because the NIH can't work with it? And in the last 1.5 years, that's what we did. So the NIA, National Institute on Aging, is working on cell senescence, which was described in the last talk. And these senescent cells are ones that zombie cells that have stopped dividing and they refuse to apoptose. And they're sitting around putting out all these inflammatory messages that are now linked to all the senescent diseases that we have today, or the aging diseases we have today. So they put through a full study, characterization in vitro and vivo, and here's just a quick results. Here's the transcriptomics. So we are able to systemically downregulate all the SAS mRNA. And in the proteome, we saw the same thing. This is with Olink. And in vivo, the results were very consistent. All of the SAS, all the inflammatory markers in the blood were systemically downregulated. And based on this, we picked out 4 important markers, GDF15, CXCL1, DPP4, and BAFF, from which we discovered all of the FDA indications, sick care indications relating to them. And you see everything on the right here. Basically everything that has to do with inflammation. And because of that, we are working with one of the largest hospital systems in the US to go after irritable bowel disease, or IBD. But how about longevity? What we actually believe is if heterochronic parabiosis does work, I wonder if our exosomes can either slow down, stop, or reverse biological aging. So that's the long-term dream. That's what we're aiming for. But a couple of things need to happen before then. First, we have to take it through the FDA. So we have human trials running. And it's safe and efficacious for IBD. Then we need to identify the right biological clock. And as you can see from today's and yesterday's talks, that clock may not actually exist today yet, right? So looking into it. Then after that, we need to scale it for prevention. And the scale, we believe we have. We currently manufacture our exosomes to a 5-liter scale to be sold into the beauty and cosmetics markets, so topical use. And we did some models, and we realized that we can get it out to 50 or even 50,000 liters. We can drop the retail price from $1,200 a unit all the way down to 10. That's how we do it. That's how we democratize this. So we believe that we have to first go after sick care, prove that this product is not only safe but efficacious, then go after prevention using exactly the same product, produce a GMP at that large scale. Then we can really democratize it for everybody. Right? So this product, not only for billionaires, for everybody. Thank you.
Okay, I'm mic'd up. Sorry. So great talk. I can see from the room and from the volume of questions that people are very interested in this. So we'll run through a few as we're essentially back on time again. So let's do a few quick questions.
All right.
I'll get that first one because it seems like one that would be very common interest. So a lot of clinical work is currently being done in Japan regarding teeth regeneration. Right. What is your opinion about stem cells and teeth regeneration?
I think we're onto something. And the thing about teeth is, if something goes wrong, you can just remove the tooth, right? So I've read up on some of it. It's very exciting, and I think they just need to execute on the translation of that technology to human beings. It's very exciting.
Very good. Which stem cell-based approaches do you see as most promising for near-term clinical use? The exosomes. And the reason why is because the exosomes mostly are quite non-immunogenic, meaning it doesn't create an immune response, right? And they're small enough, and depending on what cells they come from, probably less immunogenic. So if you put cells in, if you read a lot of the reports, even with MSCs, the cells get cleaned out of your system probably within 4 to 7 days anyway in biodistribution. Mostly go to your lung and go to your liver. So whatever's left over from the current MSC therapies are probably from the exosomes coming from it, right? So you might as well just be using the exosomes in the first place, right? And just redose whenever you need it. And lastly, aside from our teeth, which organs or systems do you think will see practical applications of stem cell regeneration first?
It's a good question.
I'm more of a systemic guy. So I think that what I would go after is probably the liver or the kidneys. Because if you can inject something through IV, it will naturally go through the liver anyway. And the kidneys, the idea here is, imagine all of the patients that are currently on dialysis machines, right? They're drawing their blood out, and it's going back in anyway, right? Put some exosomes in there, have it all go back in. Why not, right? So we're actually working with 40 different, research institutions as well as companies using these exosomes for various types of therapies, and a lot of them are very, very exciting. So keep an eye out for this.
Awesome. Yuta, thank you very much.
Thank you very much.